A little time to find us. Good afternoon. For the second time on June 27th, 2025, I am Lisa Salberg, and I am here with Tales from the Heart, a podcast from the HCMA, with a new guest, somebody new to the podcast, Dr. Jeff Bennett from the Cleveland Clinic. Welcome, Jeff.
Thank you for having me, Lisa. It's great to be here, and we all appreciate the work you do for so many families. It's a great resource for everyone.
Thank you so much. It's, believe it or not, going on 30 years next year will be our 30th anniversary of the work that we do, which blows my mind a little bit because somehow I don't feel old enough to have been doing anything for 30 years other than living. So it's been a long road, and we've met a lot of wonderful people along the way, and I'm glad to introduce you to our community. So why don't we get started by talking a little bit about what's going on with pediatric cardiology at Cleveland Clinic, and tell us what's the future going to look like there.
Yeah, so it's an exciting time. We've had a lot of growth, and in particular in our cardiovascular genetics program, which cares for children and families with HCM, we're really expanding. I think the most important focus that we've had is thinking about the best way to deliver care to families. And we don't think of HCM as a childhood or adult diagnosis. These are family diagnoses, and they are often passed along. Sometimes we're finding it in parents after we diagnose it in a child. And so providing all those resources is really important. And sometimes that starts even with plugging them into the HCMA, which is where I said it's so important for our families. But we have coordinated nursing, we've got the physiology team, and we've got a psychologist who specializes in cardiac conditions in kids, and we're able to really support these families from diagnosis to getting them back to living their lives the way they want.
So I know Dr. Zaka pretty well over the
Yeah.
years. So tell me how you and Dr. Zaka are working together, who's on the team. Update us.
Yeah, so my partner, Dr. Zaka, has been doing this a long time, and so when I came here 3 years ago, we basically just took off and running like we've been working together our whole lives, and we really think of HCM as a team sport. And so whether it's Dr. Zaka, whether it's Nikki Rush, nurse practitioner that we work with, whether it's me, our families really shouldn't notice any difference in the care that we provide. Like I mentioned, we've got coordinator nurse, we've got a physiology team, all of whom really understand HCM and really understand how we can take care of children and young adults with this.
You have a background that is incredibly strong in genetics. Why don't you tell our listeners a little bit about where you come from in terms of that genetic basis and what you find most intriguing about genetics and cardiomyopathies?
Yeah, so like you said, I have a background in genetics. That's what my PhD was in quite a few years ago now. And then even after I had finished my pediatric cardiology training, I did specialty training in inherited cardiovascular disease. And that's really where I grew to appreciate that the understanding of genetics, and not just, well, we do the test to figure out who's at risk, but doing genetic testing to understand more about the condition, understand more about the prognosis, understand more about the risks. It really helps us give the best information to the families and the best guidance for them, in addition to being able to help them understand why this happened and how this is going to impact them.
We are living in unprecedented times in oh so many ways, but we are now on the precipice of genetic therapy being available. We have clinical trials underway right now. Some gene therapies have already made it to market, but not in cardiology. So, can you talk a little bit about what you think is going to happen in the gene therapy space?
Yeah, so there's really been a couple avenues for gene therapy, and this is where really understanding the types of genetic changes that result in HCM becomes important. The current therapy that's been in trials, including at Cleveland Clinic, has largely focused on something called myosin binding protein, and this is a gene replacement strategy. Your body doesn't make enough of the gene. You can give that protein back and help support the heart that way. Other conditions, other types of HCM actually seem to have other mechanisms and are going to require sometimes more complex or different gene therapies. And so there's many kind of new inventions that are coming along, and these innovations are going to help us treat hopefully all forms of HCM, but some are going to be eligible for gene therapy before others are.
I wish there was more data out. I believe that the second cohort is complete for the Tenaya study. So
Yep.
hopefully we'll get some data readout soon, and we'll see if there is a pathway forward here. We hope that this is successful.
Yep.
In dealing with families with genetic heart disease, you mentioned that you have a mental health professional on your team. Can you tell us a little bit about how that individual is integrated into the clinic?
Yeah, so we've got a psychologist named Abby Demanchik, and she's excellent in dealing with families and especially teenagers. And if you think about it, genetic heart disease is something that tends to be progressive. Children and teenagers are finding out they have this risk factor, whether they have a diagnosis or not. They'll have a genetic risk of some condition, and that now they're going to have to live with this for decades, whether they have the diagnosis or not. They're going to be living with this, and they're going to have this on their mind. Sometimes it impacts decisions they make for sports and activity participation, something we try to help with. Sometimes it'll make decision making for having children of their own in the future difficult.
Mhm.
And this is a lot to process for anyone. It's a lot to process for adults. It's a lot. Being a teenager is hard, and so
Yes.
the these are families where we're always wanting kids to be able to talk about how this is affecting them and understand that it's okay to feel how they're feeling. And she's been such a great resource for these families as well. And again, even for adults of small children, how is this going to impact them? How is it going to impact when they inherited this gene from me? And really being able to help them process that's been an important part of our program.
I really love that component, and I think it's much more common than some of us think that the kid in the family is the first one diagnosed. They get better checkups, somebody's listening every year at a well child's exam, and then when we get to be grown-ups, we go to the doctors when we're sick. I mean, that's
Yeah.
just kind of the way it works, right? So having that child be the first in a family who's diagnosed, and then the two parents go in and who's the one? And then you find it, and then you're unlocking genetic guilt. Oh my God, what did I do? Oh my God, what did my spouse do? Or how is my spouse feeling about this fact? So you've got this family dynamic that's very, very treacherous because if they don't have some guided support to deal with the mental implications of this, sometimes things can be said that can't be unsaid.
Yeah.
And we're mad at the disease state. Sometimes people get mad at each other. And it's really sad to see that happen because they're scared. And when we're scared, we aren't thinking with our whole brain. So having a mental health professional there to help these families through these transitions and unraveling the family myths. Why did Uncle John die? Why did Aunt Sue die? What happened? And now maybe we're getting a clearer picture of what might have happened in a family. And that is emotionally very draining and complicated to process. As a family who lived through it, when you start counting up people, it's like, oof, this is a bit much.
Right.
So I love that you have that element in the program. Let's talk about therapeutics on the more clinical basis. What is available to a child today with HCM in terms of therapeutic options?
Yeah, and I think it's important to keep in mind that most children who have either a genetic risk of HCM or a diagnosis of HCM, most are not going to be on medication therapy. Medications are generally reserved for kids who have obstruction with symptoms, or sometimes symptoms related to some of the other factors, including diastolic dysfunction that we see. But the majority of children, even the majority of children who have HCM, are not on any medications that I care for. The standard kind of first line therapy that we see, a lot of children who are on medications will start with something called a beta blocker that'll slow the heart rate down. That's something that can effectively treat obstruction, particularly obstruction that you see with higher heart rates and exercise. But it also has real side effects. There are
Mhm.
telling a teenager you can take this medication, but it's going to make you a little more sleepy, and then telling a parent that your child can take the medication, but it's going to make them a little more moody is actually a kind of a tough sell for teenagers. It really highlights the
More
importance
sleep
in
and more moodiness.
yeah, so it actually really highlights the importance of understanding HCM and understanding how it impacts the heart, and really being able to choose what therapy is going to help you, what's going to make you feel better. We do have second line therapies. There's other medications, the same ones that are used in adult HCM, other calcium channel blockers, something called disopyramide that I think is used less here than in other countries now. But what's exciting is that we're starting to adopt and have trials for some of the same therapies that are now just coming on for adults. So cardiac myosin inhibitors, the first of which mavacamten is approved and is becoming pretty widely prescribed, is now on trial in pediatrics, and we're one of the sites for that trial. And this is going to be something that
And
can
that
help.
trial has been filled?
The trial is now filled. Some of the other ones are there are new trials for new medications, but for right now, the initial mavacamten trial is filled, and so hopefully we'll have some interim data on that, and coming out soon.
I have positive hopes for that one in the 12 to 17 population. I'm not quite sure how much earlier we can get in there with a myosin inhibitor in a kid. What are your thoughts? Do you see the line going under 12,
Yeah.
at least in a
It,
trial?
it really comes down to understanding what HCM and how it impacts the heart. And we talk about, mavacamten's a fantastic medication for hyperdynamic hearts that create obstruction, particularly when you create obstruction with that's harder to treat with a beta blocker. A lot of children who get HCM at a young age tend to have a little bit stiffer heart, higher BNPs, especially when you see it in infancy. And so these are hearts that may not respond as well to mavacamten, but I know that we'll end up there on trial, and it won't be commonly used under the age of 12, but I could see a role for it for sure.
I can definitely some 8 or 9-year-olds that I've worked with over the years that this could have potentially been an option for rather than going to
Yeah.
myectomy. Because who wants to have their kid have open heart surgery? So looking for an alternative to that would be really nice for family and patients. And, if they get older and they decide that they want to go another route, well, then they're fully grown and we can probably
Yeah.
more safely address the obstruction with surgery at that time. So to have some more options for the kids would be fantastic.
And
So
I and I think that's exactly right when you think about, even if we're not saving a myectomy at some point, can we save that second myectomy? Can we delay that first myectomy? That's what's really going to impact and really help the kids who need this at a younger age.
So you just said something that I'm guaranteeing if it's not a listener now, it's sometime down the road, the ears just perked up. What do you mean second myectomy?
Yeah, so
So let's talk about pediatric anatomy and what happens.
yeah, so when you have hypertrophy develop at a younger age, first of all, we always need to do really thoughtful genetic testing, because often when you see it under a year old, you're not seeing typical sarcomeric HCM, which is I think what largely you see and think of when you think of HCM. There can be other kind of syndromic causes that have dramatically different treatments. But for a child that needs a myectomy at a young age, and there's either residual obstruction or residual mitral valve disease, things that are much harder to address in a small heart, there's the risk of needing a second myectomy, whether it's progression or just repairing some of what was unable to be addressed at a younger age. And so if there are treatments for younger individuals before they delaying the time to when they might need that myectomy, are we able to do one surgery instead of two? Can we do no surgeries instead of one?
I have had many kids over the years have their first myectomies at 10, 12 in that range. And then 25, 27 is when the second one tends to occur. So it's that 10-year, 15-year, maybe some go into their 30s. Nobody wants to do that twice. Once was bad enough, twice not so much fun. And oftentimes those diagnosed much earlier have a higher likelihood of going to the ultimate treatment, which is transplant, and then you're going into the chest 3 times. So anything that we can do to limit the times in the chest, the better, in my opinion. Not to say that I have anything but mad respect for myectomies, and I think they are fantastic. But if we can avoid it, that's nice too.
Yeah, we have such an incredible surgical team, both in the pediatric and the adult side here. I never have any hesitation sending anyone for myectomy when we need it, but I always tell the families the best surgery is none surgery.
There's still a bit of a myth associated with post-myectomy life that you're fixed somehow. So let's address, we've removed the obstruction from this heart. What else is still going on in the heart once we've removed obstruction, and why is it important for these families to keep really following up?
Yeah, so you have to keep in mind that even though what we think of with HCM is this big, thick septum, and you can remove the part of that septum, you can remove some of the scar tissue associated with that, there's still the rest of the scar tissue there. There's still abnormal heart muscle really throughout the entire ventricle. So there's always going to be the risk of abnormal heart rhythms. There's a risk of sudden death still. What seems to be the case that myectomy doesn't increase the risk. Maybe it decreases it, but we don't have great data for that yet. But like we said, there can be residual obstruction. There can be mitral valve damage, whether it was pre-existing or with the actual myectomy itself. And there's certainly a significant risk of arrhythmia that may need to be addressed and considered, particularly for young kids who are needing to be able to participate in sports and activities.
For those watching on video, your background just had somebody walk through it into the piano, which is, I love when somebody walks into the background and it looks like they actually walked into a room. That was funny. Okay. So the underlying anatomy of the heart is not going to change by the myectomy, and we have to treat that heart over lifetime. Even in an adult who has a myectomy, it's not getting rid of the problem, it's getting rid of obstruction, and you still have to deal with the heart muscle. Some people feel so much better after myectomy. They're like, I don't have to do anything anymore. They come knocking back at the door within a couple, some of them are within 5 years, but definitely on the 20-year line. They're coming back and saying, I thought I was fixed.
Yep.
I'm glad you've had a good 20 years. It's time to come back to the fold.
Yeah.
We have a comment question, and it's a good just point of view. So her son was 8 when he was diagnosed, now 27, non-obstructed with an ICD. Oh, wait, implanted. Oh, he has, his device was implanted at 15. What's on the horizon that you know of for non-obstructed patients? I know of the Embryo trial. Do you want to talk a little bit about myosin inhibitors and the non-obstructeds?
Yeah. So for myosin inhibition and non-obstructive, it certainly there's less supportive data right now. It may be a matter of patient selection in order to really identify the signal and identify who will benefit from it. But right now we have pretty limited data for their use in early on in adults, and we have really none and no experience with them in children. The bigger question I think we're going to run into is when you have non-obstructive HCM, and is this because it's early and it's going to be obstructive, or is this, maybe like the case of this question, is this something that's been ongoing and has potential to have a lot of underlying fibrosis and a stiffer heart over time? Who's going to benefit from gene therapy, and what'll be the best timing? Is there a point at which gene therapy isn't going to help because it can't reverse some of that fibrosis? And certainly MRI testing is something that is going to be probably an important part of choosing and identifying the right time to administer gene therapy.
I think that's a really good point, and we should have some more clarification soon on some better guidelines on scar delineation and calculation of scar. There's a paper, I think it might be out. I'm not sure. I got to go check. But to help us figure out what the scar burden is,
Yeah.
institutions vary right now. We need some national standards there, so it's a little easier for people to get cohesive information. So, Imbria, we did a uh, clinical trial for them in their phase 2. We helped do some recruitment, and that was a positive phase 2 study in non-obstructed. Ninerfastet might be the way to pronounce it. I hate the names of these drugs because they are always tongue twisters. It works on cardioenergetics. So it works on ATP regulation. So it makes your heart more effectively use energy. This is the very layman's version. The trial will be opening up in the fall, and a 27-year-old, if they meet the criteria, could definitely be in that trial. So I would stay in touch with us to see when that trial opens, and if we can find a site near you, that might be a really good opportunity to try something outside of myosin inhibition, but still focusing on. I think we've gotten to a really cool concept in HCM research. We're not limiting the symptoms. We're not masking the symptoms with a beta blocker or calcium channel blocker. We're starting to get into the muscle, and we're trying to treat the muscle and make it act more normally. So that's what one of the goals of this drug is to make the heart work a little bit more normally with its energetic use. So that's on the up and coming. I wanted to talk a little bit about detection and how we're going to find these kids and families. And one of the things HCMA has been working on is the Children's Cardiac Safety Act. We have passed a law in 3 states now that allows the well child examination to include family heart health history questions. Can you tell us why it's important for families to be checking and asking this on a regular basis, not just once in a lifetime?
Yeah, so this is something that I felt pretty passionately about, that we haven't done as good a job historically in finding this and finding this at the right age. And I think you really come at it from 2 different directions. One is there's a family history that's known. When should I get my child checked? And it used to be that we'd say, well, 12 years old, if there's some risk factors, maybe we'll do, a little earlier. But it turns out that you're going to miss a lot of earlier onset that way. And some newer guidelines more just say, well, at diagnosis. And it gives a little more leeway to say, as soon as I know there's a family history of HCM, I'd like to meet that family. I want to see them in our clinic so we can describe, here's what HCM is, here's what it isn't. And we don't have to do a massive amount of screening at a young age. But there are times we will see early onset, particularly with some of the certain genetics. We'll see early onset changes, and we'll see things that suggest there's underlying fibrosis even before there's a clinical phenotype. And be able to understand what the heart does over time, that's how you can make good decisions. As you mentioned earlier, my partner, Dr. Zaka, he always says, good data allow you to make good decisions. And so I like to get families in at a young age and really help them understand what we're looking for and complete screening over time. We'll see adults that have no real phenotype, and their children, at a relatively young age can be pretty significantly impacted. So that's really the first avenue, is how do we get families in sooner, and how do we get them the genetic testing they need, the screening they need, and really the sports discussion that they really need. And then the other side of things is when we don't know the family diagnosis, and sometimes even just a pediatrician asking the right question is gonna, well, wait, there's an uncle that died early and grandfather has some heart failure but doesn't know why. This sounds like we need to investigate further. And it's not always on the pediatrician to try to sort through all the
Mhm.
details and figure it out, but to understand, here's someone who needs a little more evaluation and a little more thought, and even just a screening echo and a good family history meeting with a genetic counselor can sort through a lot of that information. And so really identifying families who didn't know they have that condition is that other avenue where we have kind of another point of entry into our program.
So the mechanisms that we're looking at are simple. They're not going to catch everybody. I don't know that there is a system that can catch everybody, but by asking those family heart health history questions, by asking about the individual symptoms much more specifically, do you get short of breath with exercise? Do you ever feel dizzy when you stand up? These questions might help the pediatrician make that proper referral. This is not just for HCM. This would be for the channelopathies, the congenital defects, Marfan's. There's a lot of different diagnoses that we could uncover if we just ask the right question and enter into the right dialogue that will get us on that referral pathway. And it is the safest pathway that we have identified to go from I need a conversation with a healthcare provider to I need a test. If you jump immediately to the test, the false negatives and the false positive numbers are so confounding that we end up doing damage to people by labeling them with something that's not really a thing. And then you spend years getting it off their medical records because it was a community ECG that actually the lead placement was wrong or whatever. And I fought these battles to try to get records expunged from records or files of
Oh,
patients. It's kind of annoying. So if we start with the healthcare professionals and a really intense conversation about what's going on in that family and a referral to a pediatric cardiologist as a starting point, if that pediatric cardiologist needs expert advice on a particular disease, they work within their network to go find that specialist. Or if you're a family in a rural community and there's only one pediatric cardiologist and you don't know where to turn, well, that's when you come to the HCMA website, go to our directory listing, and look up pediatric cardiology in your area, and you can find a HCMA recognized center of excellence for peds. We are growing the network for the pediatric programs. We recognize that most of our programs are adult, but many of them have other programs that they're aligned with that are pediatric that we had informal relationships with over the years. And now we're formalizing those with their own directory listings and their own lists on our website. So it makes it easier for people to find. So as we go through this whole legislative process, we're hoping not to overwhelm the pediatric cardiologists, and it has not happened here in New Jersey. Our pediatric cardiologists are just fine. They're handling the volume. They got this, and we've got their back. And Virginia will be next, followed by Nevada. So we should just be asking these questions of every well child's exam. You don't have to wait for it to be law to have the practice in your pediatric cardiology or pediatric program or your family practice program. You can start asking the questions now. And just by asking questions, you uncover so many myths. How many people have you met, Jeff, that said, well, grandpa had a heart attack at 40 or aunt had a stroke at 38 or 45, and these numbers they're just not they're not mathing. So how many family myths have you come up with? I got a bundle.
yeah, we see this all the time of families who something happened, we're not sure what it was, or they had a diagnosis of, you know, I spend as much time undiagnosing people sometimes as I do diagnosing them. But, oh, this was all hypertensive heart disease, and then, well, three other people in your family have HCM. So I'm gonna guess that hypertensive heart disease might have been something else. And so really, and one important point I think that you're mentioning about the pediatricians asking these questions and really trying to delve into the family history is so important. And I think we owe it on the pediatric cardiology side, not just our program, but all programs, to provide that access to pediatricians when they have a question. When they say, "Oh, we got this history. Is this someone who needs to be seen?" Of course, yes. Here's how you get them into our clinic. Like, since I've been at Cleveland Clinic, we've changed the order so that if you've got a family history that needs to be investigated, the pediatrician can click this button, they'll get into our clinic, and we can take it from there. So making it easy, trying to do what we can to make it easier for that referral to happen and easier for that conversation to happen, I think has really enabled the pediatricians to delve into this because they know what to do if they find something.
And the find something is wide. It could be structural heart disease, it could be an arrhythmic based disorder. There's so many different things that could go wrong with a human heart and run in families. So we have to make sure that we're looking at them all in a very cohesive manner. So here's one of the biggest differences to me between pediatric cardiology and adult cardiology. In adult cardiology, HCM is very, very clearly defined. We do confuse it sometimes with amyloid or with Fabry's disease, but it's pretty well defined. In pediatrics, we're talking about some other groups of individuals that we don't talk about as much in the adults, and that's the RASopathy kids, and that is all of the syndromes that are out there. So we do have many families in our network, which are Noonan's HCM. So I thought we would take a minute to talk about our RASopathy, big-hearted little ones. And what is a RASopathy?
Yeah, so this is something that I've spent a lot of time working with families on because it's so important and the treatments are so different and unique. So that's a whole subset of people. We just spent so much time talking about myosin inhibitors. It's a whole subset of individuals who may have real symptoms that can't get mavacamten, can't get
Right.
aficamten. And so this is when, the RASopathies are this, broad group of conditions. Generally, Noonan syndrome's the most commonly known, but there's some other conditions that are either similar or kind of along the same line, where this signaling pathway is dysregulated and can result in really multi-systemic involvement. But from a cardiac standpoint, you can see both congenital heart disease, which is pretty well recognized, as well as HCM, hypertrophic cardiomyopathy. It's probably not typical, or it definitely isn't typical sarcomeric HCM. So we'll even differentiate it very carefully when we consult, because it is an important distinction. But you can still get obstruction. Really, you can get it on either side, either or the left or right, and it can come on at any age. Some types of RASopathy, you'll see hypertrophy essentially in a newborn, and it can cause really quite severe impact to the baby, growth failure, and need myectomy, even before within the first year of life. Others, it seems to be more of a lower risk, something that can happen over time, something that is subtle, tending to not be as symptomatic, but all of them can be, really impactful. Understanding the genetics can predict to some degree, but not a perfect degree, who's at risk for hypertrophy. Some of the genes are actually very, very significant risk, and we just say it's more a matter of when, not if. But maybe more importantly, the treatments can be different. Some of these young kids do require surgery at a young age, but there's also some medications that are used mostly off-label that can impact this pathway in a manner to help reverse some of this HCM, and that's something that, if you have a child with a RASopathy, or you have RASopathy yourself with significant impact to the heart, that's a question you need to be asking your cardiologist is, are there small molecule inhibitors? Are there new medications that may positively impact my heart?
I'm aware that the RASopathy network is kind of lobbying for a label for, I forget which drug it is right now. Sorry, guys, I forget. Uh,
Trametinib.
yes, that's it. I knew you would know. So it shows the value of advocacy too. You've got the parent saying we want access, you want the doc saying we want to prescribe, but what's stopping you? If you're the doctor, they're the parent, they want to decide. So you got some regulatory factors that come into play, because maybe there hasn't been a safety study done on children, or maybe the population was a little bit older and they want to protect the kids. But sometimes you got to let the docs be the docs and try the meds that they think might work on their patient. They're approved in other spaces, they're just not approved for this. And you get into a problem if it's not approved, then payers don't typically want to pay for it. So
Yeah.
then we get into this, the doctor and the patient agree, but a payer system says, we haven't seen enough data. Sometimes you don't have a lot of choices.
Yeah,
And
it's been a very significant issue when we've used it in the past.
yeah, but we keep trying. And that's part of what we do here. We keep talking about the issues that need to be changed, and we hopefully try to move them towards the point of change. So I'll leave you at this first interaction on your first podcast participation. So thank you so much for that. What do you hope to see happen in the next couple of, let's say, year or two within the HCM space for pediatrics? What do you think is coming?
Yeah, I hope we're able to bring some of the therapies that are trialed in adults to children. And how do we evolve our use of myosin inhibition? How do we provide gene therapy for younger individuals who really need it? It would be great to see more and more research and things that we're working on right now to understand the genotype phenotype correlation, a fancy word for saying how do we take what's in your family and understand it better and predict what the heart is going to look like and how it's going to respond. And I think these are all avenues that we need to work on in order to provide the best care for adolescents who have HCM, because they do have it. It's not just adults.
I was 12 years old when I was diagnosed. The world was very, very different. It's actually a very scary time to be diagnosed. 1980.
Yeah.
We had nothing. Toolbox empty. Beta blockers. Have a nice day. It has come a long, long way. And young people have a much greater chance of living a normal life with their HCM. In my podcast earlier today, I was talking to Dr. Amin about the other end of the age spectrum. How I have clients that I've been working with for almost 30 years now who were middle-aged when I met them, and they're in their 80s, mid-80s now. And yes, I get notices that somebody has passed, and it's a little sad, but they lived their whole life. And some of them, maybe 20 years ago, we got together and I helped them find a doc and they got some surgery and probably led them to a bit more life. So when you manage HCM, you can live a long life. We have had
Yeah.
many clients in their late 80s, 90s, and even one that hit 100. So your kiddos have a lot of possibility for a normal future. And I know it's overwhelming to have a child diagnosed. My child was diagnosed at 10. Very different than your own disease state, very different than your own diagnosis. So we need to do more to support the families who are going through these diagnoses. We need to do more to support our kids with good therapeutic options, up to and including gene therapy. So I'm super excited about what the future holds, and I hope we have you come back a couple times a year to give us some updates of what's going on out there. And we thank you so much for joining us on Tales from the Heart.
Yeah, thank you for having me. It was wonderful to be here, and anytime you want me on, I'll be here.
We will be asking. Don't you worry about that. You have a good day, and thank you, everybody, for joining, and happy 4th of July to all.